Vanakkam. We need to remember one very important point at the very beginning. When we deal with fractures, we only treat them, but the healing comes from within, because bone is one of the very few tissues in the body that can regenerate on its own. That is, it can heal without forming a scar. So, our treatment modality, whatever it is only going to decide the method of healing, whether it's going to be primary direct healing or secondary indirect healing. And both these processes are amazing with so many factors influencing them. So, to ensure a good outcome after management of a hand fracture, we need to understand the processes of bone healing and help it along. And that is what we shall be learning in this video. The aim of bone healing is to bring back the strength of the bone, and what is needed for the healing to proceed is stability. The strain between the bone fragments must be reduced for the healing to proceed. This stability may be provided immediately or gradually. It depends on the process of healing. This intricate regenerative process of bone healing can be classified into primary or direct healing, where lamellar bone forms directly, whereas in secondary or indirect healing, lamellar bone forms through endochondral or intramembranous ossification. To understand the processes of bone healing, we shall learn about indirect healing, when it occurs and the phases of this indirect healing, when direct healing occurs and the different types of direct healing, that is contact healing and gap healing, and finally we shall learn about the factors affecting bone healing. We shall learn first about indirect or secondary bone healing because it is more common. It involves healing through both endochondral and intramembranous bone formation. Anatomically perfect reduction and absolutely stable conditions are not required for this type of healing. But at the same time, it must be remembered that too much of load or movements at the fracture site can result in delayed healing or non-union. When does this type of indirect bone healing occur? It occurs when non-operative fracture treatment is done, like for instance application of a POP slab. Even in operative treatments where some motion occurs at fracture site, like intramedullary nailing or external fixation or internal fixation of comminuted fractures, indirect healing can occur. The entire process of indirect bone healing occurs in three phases: the inflammation phase, which lasts from 1 day to 1 week, regeneration phase, which lasts from 1 week to 1 month, and the remodeling phase that lasts from 1 month to 1 year. I have used these particular time frames so that they are easy to remember, but there is a lot of variation. Let us see in a pictorial way how the phases of bone healing occur. First is the inflammation or hematoma phase, which lasts from day 1 to day 7. This stage begins immediately following the fracture. The blood vessels supplying the bone and the periosteum are ruptured during the fracture, causing a hematoma in and around the fracture site. This hematoma forms the temporary frame for subsequent healing. At the same time, injury to bone results in the secretion of pro-inflammatory cytokines, about which we shall see later in this video. These cytokines act to stimulate essential cellular biology at the site. That is, they attract macrophages, monocytes and lymphocytes into the hematoma site. The cells migrate into the hematoma and act together to remove damaged and necrotic tissue. The stage of inflammation officially ends here, and the resulting mass of clot and cells is sometimes called the hematoma callus. Now the stage of proliferation starts. Vascular proliferation helps to promote angiogenesis and is stimulated by vascular endothelial growth factor. Now a fibrin-rich granulation tissue begins to develop. Mesenchymal stem cells are recruited to the area, and due to stimulation by the bone morphogenic proteins, they begin to differentiate to fibroblasts, chondroblasts and osteoblasts. Chondroblasts secrete collagen and proteoglycans, which forms the matrix for the bone formation. They also produce fibrocartilage and hyaline cartilage, and this is the first to provide mechanical stability. At the same time, adjacent to the periosteal layers, a layer of woven bone is laid down by the osteoprogenitor cells. Remember, it is only woven bone that is laid down first. This is now known as the soft callus or fibrocartilaginous callus and is ready by 10 days. This soft callus contains only hyaline cartilage and woven bone, which must be converted to lamellar bone for getting back its original strength. So lamellar bone must be formed both from the hyaline cartilage and the woven bone. This involves two processes. The cartilaginous callus begins to undergo endochondral ossification. The cartilaginous callus is resorbed and begins to calcify. The process of woven bone being laid down subperiosteally continues by the process of intramembranous ossification. At the end of this phase, that is, at the end of 1 month, a hard calcified callus of immature lamellar bone forms. This lamellar bone is in the form of trabecular bone, which is characteristically seen in spongy bone or cancellous bone. Now the fracture is considered healed. The bridging of the central hard callus provides the fracture with a semi-rigid structure which enables weight bearing. Therapy can be started now, but the process of healing continues with the stage of remodeling. As we have seen, though the hard callus is rigid and provides stability, it is still not normal bone. Remodeling of the hard callus into lamellar bone structure with the central medullary cavity is the final step, and that is the phase of remodeling. It usually starts at about a month, but the whole process may take years. The process substitutes the woven or trabecular bone with lamellar bone. The immature lamellar bone or trabecular bone is first resorbed by the osteoclasts, creating a shallow resorption pit known as a Hauschip's lacuna. Then the osteoblasts deposit compact bone within this resorption pit. What actually starts off this process of remodeling is axial loading, that is, movements. When axial loading of long bones occurs, an electropositive convex surface and an electronegative concave surface are created. This activates osteoclastic and osteoblastic activity. As the callus matures and transmits weight-bearing forces, the portions that are not physically stressed are resorbed, and in this manner the callus is reduced in size until the shape and outline of the fractured bone has been re-established. External callus is replaced by lamellar bone structure and the internal callus is replaced by a medullary cavity. Though we have seen the three processes that constitute the indirect bone healing, they do not occur one after the other but overlap each other like this. Now we shall see the biological factors that have played important roles in this process of indirect bone healing. They are the pro-inflammatory cytokines, cells, and growth factors. There are many pro-inflammatory cytokines, but some of the important ones are the bone morphogenetic proteins or the BMPs, which stimulate conversion of mesenchymal cells to osteoblasts, tumor necrosis factor alpha, and the interleukins, interleukin 1, 6, 11, and 23, which act to stimulate essential cellular biology. The cells involved in the indirect bone healing process are of two types. Those cells that are important for debridement and activation, that is the macrophages, monocytes, and lymphocytes and platelets, and those important for regeneration, the fibroblasts, chondroblasts, mesenchymal cells, osteoclasts and the osteoblasts. Apart from the cytokines and the cells, there are important substances known as growth factors which influence the process of indirect bone healing. The transforming growth factor beta stimulates mesenchymal cells to produce type 2 collagen and proteoglycans, which are important for the matrix formation. The insulin-like growth factor 2 stimulates type 1 collagen formation, platelet-derived growth factor, which attracts inflammatory cells to the fracture site, and the vascular endothelial growth factor, which helps in angiogenesis and vascular proliferation. We shall now see the process of direct or primary bone healing. The features of this type of healing are: there is no callus formation, directly lamellar bone, Haversian canals and blood vessels are formed mainly due to osteoclast and osteoblast activity alone, and the process usually takes from months to years. We have seen the conditions where indirect bone healing occurs. When does this direct healing occur? It occurs characteristically when fracture ends are fixed together with compression and absolute stability is provided. That is, there is the least amount of interfragmentary strain. There are two types of this primary healing. It can occur through contact healing or gap healing. After plate and screw fixation, when the gap between bone ends is less than 0.01 millimeter, contact healing occurs. But when the gap is between 0.01 to 1 millimeter, gap healing occurs. Let us first see the process of contact healing. We have already said that when there is a gap between the bone ends of less than 0.01 millimeter and absolute stability is provided, contact healing occurs. In such instances, cutting cones form at the ends of the osteons. The tips of the cutting cones consist of osteoclasts. These tips are known as the cutting zone. In the reversal zone, there are active osteoblasts that lay down new bone in the cavities that are created. Slowly, the new bone matures into lamellar bone and is called the closing zone. The Haversian systems enable blood vessels carrying osteoblasts to enter the area. They cross the fracture line and generate longitudinal cavities. They move at a rate of about 50 to 100 micrometers per day only. This causes the bony union to generate while also restoring the Haversian systems, which are formed in an axial direction, that is, perpendicular to the direction of the fracture line and along the direction of the bone. As a result of this process, there is fracture healing without a periosteal callus forming. If the gap between the fracture ends after fixation with plate and screws is more than 0.01 millimeter but less than 1 millimeter, gap healing occurs. This is different from the process of contact healing that we have seen. In gap healing, bony union and Haversian remodeling does not happen at the same time. During this process, the fracture site is filled largely by lamellar bone, which runs perpendicular to the long axis and needs secondary osteonal reconstruction. This phase is complete by 8 weeks. It is not strong at all as it runs along the fracture line and perpendicular to the axis of the bone. The primary bone structure is eventually replaced by longitudinal revascularized osteons, as we have seen in the cutting cones process. To compare contact healing and gap healing, contact healing occurs when the fracture ends are in close contact less than 0.01 millimeters, whereas gap healing occurs when there is a space of about 0.01 to 1 millimeter between the fracture ends. In contact healing, lamellar bone is formed primarily parallel to the axis, whereas in gap healing, lamellar bone is formed perpendicular to the axis of the bone. The common features between contact healing and gap healing are: cutting cones are ultimately involved, there should be an interfragmentary strain of less than 2%, and rigid fixation must have been done. We shall now see the general factors that influence fracture healing. There are 4 main sets of such factors: injury variables, patient variables, tissue variables, and treatment variables. Let us first consider the injury variables. The factors about the injury that can influence the fracture healing are the open fracture, the severity of the injury, intra-articular fractures, segmental fractures, soft tissue interposition between fracture ends, and reduced blood supply. We shall now consider how each of these factors can influence fracture healing. When there is an open fracture, it would be associated with soft tissue disruption, fracture displacement, and sometimes significant bone loss. And subsequently, blood supply to the bone may be disrupted, causing a necrotic bone and hence development of a very poor fracture hematoma, which is so important for fracture healing. The more severe the injury would mean increased volume of necrotic tissue, which will impede the migration of mesenchymal cells and decrease the rate of vascular proliferation. If the fracture is intra-articular and alignment and congruity of the joint surface is not restored, it may lead to joint instability. If the fracture is not rigidly stabilized, it may lead to delayed union or non-union. In case of segmental fractures, the blood supply to the middle fragment, especially the medullary blood supply, will be disrupted. If there is also associated severe soft tissue trauma, the periosteal blood supply may also be compromised. Hence, there is a probability of delayed union or non-union. And if there has been soft tissue interposition between the fracture ends, and it could be due to muscle, fascia, tendon, or even nerves and vessels, obviously, healing of the fracture by the processes that we have seen cannot occur. Reduction in blood supply can also compromise fracture healing, but this could be due to either a severe bone injury or due to the inherent nature of some bones which have a limited blood supply, like the scaphoid. There are some patient variables that can affect the fracture healing. Let us see them now. Factors like age of the patient, nutrition, hormones, drugs, smoking, and diabetes. When considering the age of the patient who has sustained a fracture, we need to remember that infants have the most rapid rate of fracture healing and remodeling. The rate of healing declines with increasing age up to skeletal maturity. But after completion of skeletal growth, there is no known decline in the rate of fracture healing with age. Nutrition plays an important role in fracture healing. The cell migration, proliferation, and matrix synthesis need energy for the process to continue. And the synthesis of collagens, proteoglycans needs proteins and carbohydrates. In severely malnourished patients, obviously there will be poor fracture healing. Hormones too have a role to play. Corticosteroids inhibit the differentiation of osteoblasts from mesenchymal cells and also decrease the synthesis of bone organic matrix components. The role of growth hormone is uncertain, but it has been proved that thyroid hormone, calcitonin, insulin, and anabolic steroids enhance healing of fractures. Some drugs too can influence fracture healing. Non-steroidal anti-inflammatory drugs have been known to inhibit cyclooxygenase 2, which leads to decreased production of prostaglandin PGE2, which plays a very important role in cell migration and differentiation. Similarly, bisphosphonates, which is a drug used for treatment of osteoporosis in elderly patients, can cause inhibition of bone tunneling in intramembranous ossification and remodeling in endochondral ossification by osteoclasts. In patients who are chronic smokers, we need to note that nicotine slows cartilage differentiation and delayed hard callus formation. A study has shown that smokers are 37% more likely to develop a fracture non-union after sustaining an open tibia fracture. Diabetes is another variable to be considered because studies have shown that untreated diabetic rats had a 29% decrease in tensile strength and a 50% decrease in stiffness compared with controls 2 weeks after sustaining a fracture. Next, we shall consider the tissue variables that can influence the fracture healing. It could depend on the form or type of bone that is fractured, bone necrosis, bone disease, and bone infection. When we say the form of bone or type of bone, we mean whether it is cancellous or cortical. These two types of bones have differences in surface area, cellularity and vascularity. Cancellous bone surfaces usually unite rapidly because there is more contact and more vascularity. But cortical bone, due to its smaller surface area per unit volume and less extensive internal blood supply, the healing is not as good as for cancellous bone. Necrosis of bone is a significant factor as far as fracture healing is concerned. If one fracture fragment is avascular, the fracture can heal, but the rate is slower. If both fracture fragments are avascular, the chances for union decrease even further. And this reduction in vascularity could be caused by trauma, surgery, infection, prolonged use of corticosteroids, and even radiation treatment. Fracture of a bone with an underlying bone disease can also affect the healing of the fracture. Fractures through primary or secondary malignancies or infected bone will have poor healing. But fractures through bones with non-malignant conditions like simple bone cysts or Paget's disease can heal quite normally. When there are fractures through osteoporotic bone, the time to healing is increased. Bone infection in fractures can slow or prevent healing completely. This is because the cells are diverted to attempt to wall off and eliminate the infection, and energy consumption increases. Moreover, infection may cause necrosis of normal tissue, edema and thrombosis of blood vessels, thereby slowing the process of fracture healing. Apart from all these factors, the modality of treatment chosen can also affect or modify the fracture healing. The apposition of the fracture ends with the treatment, the fracture stability provided by the treatment done, POP casting or slab application, intramedullary nailing, and the use of plate and screws for treatment can modify the fracture healing. The use of bone stimulators can also modify this healing. Good apposition of the fracture ends is very important for healing as it decreases the fracture gap and also decreases the volume of repair tissue needed to heal the fracture. Whatever the treatment modality chosen, fracture stability must be provided to reduce the interfragmental strain and allow healing. And this is particularly important when there is associated soft tissue injury, blood supply to the fracture site is marginal, or the fracture occurs within the synovial joint. The application of a plaster of Paris cast or slab is a standard treatment for some fractures. However, we need to remember that a POP can only give relative stability and the quality of healing may not be very good initially. If early mobilization is started, there would be more fibroblast conversion rather than osteoblast conversion, and this will result in a very weak healing. When the technique of intramedullary nailing is used to treat a fracture, secondary healing with callus formation will occur. If a large sized nail is used, it may damage the medullary blood supply when reaming is done. In that situation, healing of the fracture will depend on the periosteal supply and the soft tissue attachments only. When plate and screw fixation is done for a fracture, direct bone healing occurs with no callus formation, and osteons grow directly as cutting cones as we have seen, and lamellar bone forms primarily. Finally, we come to the role played by bone stimulators. First, we shall consider electrical stimulation. The Wolff law states that bone remodels in response to stress, and bone is a piezoelectric tissue, so it builds an electric charge, and we have already learnt about this a few minutes ago. That is, the compression side of the bone, that is the concave side of the bone, is electronegative, and this stimulates osteoblasts, while the tension side of the bone, the convex side, is electropositive and stimulates osteoclasts. To enhance this effect, extrinsic manipulation in the form of electrical stimulation can be done. The second stimulation of bone that can modify the healing pattern of the fracture is ultrasound. Ultrasound stimulates bone in a mechanical manner. Low intensity pulsed ultrasound transmits energy to bone and enhances healing. I hope you enjoyed this video. I enjoyed making it. Please click on the shown links to see more videos put up in this channel. And do not forget to subscribe to stay connected with the latest in learning hand surgery. Vanakkam.